Thank you, Dr. Chandrama. And so, these are newer advances in perimetry. Even I'm not familiar with all of them. I've just tried to collate them together. But there are some bits and pieces that I use, and I'd like to enumerate about that in particular. For many years now, standard automated perimetry, that's white-on-white perimetry, has become the gold standard for the tests that we do. We usually, if you're a Humphrey user, you'll prefer a 30 or a 24-2 with a CETA standard strategy. If you're an Octopus user, you could use the G1 or the or the 30 program, and you would prefer either the top or the dynamic strategy. So advances have focused on trying to get more efficacious and make sure that your recordings are accurate, so that you can detect earlier the damage to the, you can detect functional damage earlier. Now contrast this, that many people in this room were brought up on perhaps a Jerem screen, Goldman perimetry, and then had migrated to Humphrey perimetry, where the strategy used was threshold. And then the CETA strategies came up, and that was an advancement because it helped save time. At that time, the traditionalists said that threshold is better because because of the bracketing strategy, you are able to assess the retinal sensitivity at each point better, and that the CETA is basically a supra-threshold. It's a compromise to save time. So the idea is, ideally, we need to look at perimetry. We should be able to screen populations. We should be able to reduce the testing time, and we should be able to test specific locations more energetically. So we have visual field apps which are available. iTune has one, and they can be used for self-monitoring. I talked about the strategies. There's a threshold strategy. There's a CETA strategy which came in, and I now am given to believe that there's a CETA faster strategy which has come in, which takes still more or less time. So there are lots of types of ganglion cells. Progressive damage to the ganglion cells eventually goes on to manifest as a functional field loss. Can we target specific ganglion cells so that the disease can be picked up earlier? So we're looking at the magnocellular, the parvocellular, and the coniocellular variety of the retinal ganglion cells. Shortwave automated perimetry, that's the blue on yellow test. It came in with a lot of fanfare earlier. It was placed on the Humphrey on the threshold strategy. It took about 25 minutes to do. Patients, once got it done, never wanted to go back to it. Perhaps a good test if you would target patients with ocular hypertension, apparently normal disc, and you were looking for some changes. The problem was that the test took too much time. Patients would actually fall asleep. Octopus, at that point of time, came out with the blue on yellow using the faster top strategy. So that's when it became more patient-friendly. Eventually, Humphrey also introduced it on the CETA strategy. So the advantage of the blue and yellow test was that it was supposed to detect damage 3 to 5 years before it manifested on conventional white-on-white perimetry. Coming up on the faster strategy, it saved time. Then we had the frequency doubling perimetry, which focused on the magnocellular cells and determined contrast sensitivity using the doubling frequency stimulus. Again, the idea was to use it as a tool to assess early changes. And once you detected a change, you could go on to your standard 24-2 or a 30-2 pattern on the standard white-on-white perimetry. Then there is high-pass resolution perimetry, focuses on the parvocellular cells, using high spatial and low temporal frequency stimulus. Kinetic perimetry is what I have been using for the last 3 years for all patients with advanced glaucoma. We find it very effective in being able to at this point we have been forming a baseline, and we find that patients have received it quite well as compared to the standard white-on-white perimetry that we have been doing. We have done about 135 cases now, and we are trying to develop our own algorithm for the stimulus size and speed so that we can now introduce it as a part of our routine testing for all our glaucoma patients and not focusing just on patients with advanced glaucomas. Then we have flicker perimetry, which is looking at intermittent flashing stimulus on a uniform background. The advantage is that the cataract does not affect it significantly, and it's focused on the magnocellular pathway. Then there's motion perimetry, which is focused on the magnocellular pathway. It's another way of trying to pick up early changes in glaucoma. There's rare bit perimetry. The focus eventually is to be able to detect changes before conventional perimetry is able to pick it up. A lot of focus in perimetry has been on developing algorithms to assess progression. So the Humphrey looks at the visual field index. The octopus looks at the trend analysis, but sometimes trends can show a stable change. But if you look at an event-based analysis, you could find that there is a change. If you look at a cluster analysis, or a corrected cluster analysis, you can find that even though the loss variance and the local defect tend to be stable, there is a change which is statistically significant happening in these quadrants. So in patients with advanced glaucoma, the trend analysis may be stable, but when you do an event-based analysis, you find that there is a change. This is very significant for us to keep in mind. So newer advances in perimetry are something that we all want. We want them to perhaps replace our standard white-on-white perimetry as of today, but it's still going to take time. It's going to require studies over a period of time. Until that time, white-on-white perimetry stays the gold standard. Thank you very much.